Well, hello. Welcome to another session of Surgical Pathology Digital Slide Review. I'm Dr. Louis Hassel, and our program is part of the Digital Anatomic Pathology Academy. Our topic today is about some of the pitfalls in GYN pathology, and specifically, I'd like to touch on tumors that may masquerade or be mistaken for high-grade serous carcinoma. This is surprisingly a common problem and comes to us in a number of fairly recent cases. So here's the first case, a patient who was seen first a few years ago and diagnosed with serous ovarian carcinoma on the basis of this material and a prior biopsy, which had reportedly shown some positivity with p53 in a portion of the tumor. However, here at resection, that stain was not repeated, and there are a couple of clues that help us to perhaps rethink that diagnosis in retrospect. Now, the first clue, of course, in this situation for us, sadly, was that she had not responded in quite the typical way to treatment with conventional chemotherapy for serous carcinoma. So at low magnification, we see that we have an arborizing, gland-forming tumor, a lot of debris around, and a minimal amount of stroma. But we also see here off at the edge a little bit of an area that looks a little different. And also up here, we see some additional areas that look a little bit different. So let's just take a look at this, first of all, to see what this clue was that might have been overlooked. Well, as we look at this glandular tissue, we see that it's tall columnar cells, occasional PEG cells, maybe a little stratification, and a little bit of loose stroma around it. And over here, some similar tissue with a little bit more hemorrhagic stroma that looks a little bit more typical for endometriosis, tall columnar cells. And these cells here do not look atypical. So while endometriosis is common and may be associated with tumors, the most frequent association in tumors is not with serous carcinoma, but with endometrial tumors, clear cell tumors, and so forth. So let's look at, with that in mind, at this tumor and say, what is here that was deceptive? Well, the tumor cells are high grade. There's a lot of inflammation around, and we see that these nuclei are enlarged with macronucleoli. There's certainly a degree of papillarity here with sort of tufting off of the main tumor surface. And even here we see maybe even some suggestions of clear cell type morphology. It looks high grade. Immunophenotypically, this would be a case where we'd want to study this scenario and evaluate whether or not this was an endometrioid-derived tumor or an endometrial carcinoma, or whether in fact it was serous carcinoma as originally advertised. But the gland-forming character, the tall columnar cells, the background of endometriosis should all be clues that this may not be high-grade serous carcinoma, but may in fact be endometrioid adenocarcinoma, which is what eventually proved to be true, although it was not an entirely straightforward endometrioid carcinoma. So in thinking about ovarian serous carcinoma, it's important to recognize that our current understanding is derived in a large part from the Tumor Cancer Genome Atlas, the TCGA data, that has been very useful in dividing serous tumors into primarily two distinct groups. And that main differentiator there is those that have TP53 mutation as opposed to those that do not. And the treatment responsiveness, treatment regimens for these two types of tumors, of serous tumors, is very significant. Now, Not surprisingly, these groups rather conveniently divide into the mostly low-grade serous carcinomas and or borderline tumors that lack TP53 mutation, and the high-grade tumors that have the TP3 mutation. So that's the first distinction here, is it a high or low grade? And then the other question, as we've just indicated, is it a serous tumor or a non-serous tumor that may have, therefore, a different arm of pathogenesis and different arm for treatment. We'll discuss a little bit later the so-called SET type tumors, which are also high-grade tumors and which have quite varied morphology, solid, endometrioid, or transitional-like morphology that nevertheless need to be treated similar to serous carcinoma. So let's look at another case that also came as a potentially serous carcinoma to our consultation service. And here we see at low magnification two things. We see one portion of the tumor that looks solid, bluish, and another portion of the tumor that looks to have another architecture, a somewhat cystic component, maybe with macropapillae, and a more solid with dilated glandular tumor component. So looking first at this more low-grade appearing area, this looks like almost just a typical serous cystadenoma. There's really not any second-order branching here. And although there may be a little degree of atypia, this is really not any degree of atypia to be too worried about. So maybe just a benign serous tumor coincidentally occurring with this tumor over here. This other area here looks a little bit more concerning. We've got sort of dirty necrotic tissue or material in the lumen. And as we look at the cytology here, we see a helpful finding here, these foamy macrophages. Well, anyone who does endometrial pathology knows that that's a hallmark of endometrial carcinoma in the endometrium, and likewise when seen in the ovary. So here we're seeing a fibromatous background with these more atypical cells, occasional droplets of mucin. There is some nuclear atypia here, some tufting, but many of these cells are, again, still rather columnar looking rather than a cuboidal or serous type of tumor. So we would be concerned, based on the macrophages, based on the columnar morphology, that this may be an endometrioid tumor, maybe borderline or maybe malignant. And then we come to the higher grade solid area here that we will look at with greater attention. And we see here that we again have areas of necrosis. We have obviously very high NC ratios because this is a very blue tumor with very little cytoplasm. The cells are stratified and generally appear somewhat columnar. They do not have that cuboidal or polygonal appearance of serous tumors. We do see some slit-like spaces here that might be seen with some serous tumors. So it's understandable how that serous carcinoma could enter into the differential here. But again, we have a background of probably a lower grade endometrial tumor, an endometrioid adenofibroma, and this more complex and aggressive looking neoplasm with central necrosis, some solid differentiation, probably moving it into the FIGO2 category that would raise consideration for an endometrioid adenocarcinoma. Now, in this circumstance, the diagnosis was made of serous carcinoma without the benefit of p53 staining and other markers to verify that derivation. So perhaps that morphologic confusion can be understood, but should not be excused because the therapeutic distinction is so vital in these patients that it is important to make this distinction. So TP53 or p53 stains are not easy to interpret. And in fact, although p53 staining is a surrogate for the presence of TP53 mutation, the pattern of staining can be quite variable, and therefore imputing the presence or absence of a mutation is fraught with some difficulty and requires a bit of experience. Of course, the easiest circumstance is when you have diffuse positive overexpression in the nuclei, and that is characteristic of a TP53 missense mutation. A little bit more difficult sometimes to distinguish is the diffuse absence of expression in any nuclei of the tumor. Now, you should still see some internal control expression in the nuclei of stromal cells or non-neoplastic cells. And this is characteristic of a TP53 insertion or deletion, truncation type of mutation. A much less frequently encountered pattern is that of cytoplasmic staining with p53, with or without some degree of nuclear staining. This also is characteristic of a TP53 mutation, but it's one that is present in the localized domains that result in loss of function and the inability to enter the nucleus. Now, in rare cases, you can still see wild type expression, sort of a mixture of some cells positive and some negative, of p53, even when there is a TP53 truncating or splicing mutation. And because of this, you should not be afraid to suggest the value of mutational analysis for TP53 because the treatment distinctions will be so important. If other features, other immunohistochemical and morphologic features are strongly suggestive of p53 mutation. So here's a nice illustration drawn from the publication by Dr. Scobell and colleagues. Illustrates these four patterns. So here in panel A, the wild type pattern. Here in panel B, the diffuse positive staining of all the tumor cell nuclei. Notice the internal controls here of wild type stroma. But every nucleus positive and very uniform positivity in those cells. Here, the truncating mutation or loss in all of the tumor cells. This is probably from an endometrial carcinoma, as we see here, or excuse me, from the endometrium, because you've got some benign glands in the background here that have positive wild type staining as well. And then this last panel is the cytoplasmic pattern with diffuse cytoplasmic and nuclear staining. Now, in this situation, we've got fairly even staining of the cytoplasm and the nucleus. In some circumstances, because of the nature of that mutation, it can totally inhibit entrance of the p53 molecule protein into the nucleus, and therefore the nucleus may stain negatively in that circumstance. So let's talk just briefly about the solid, the pseudoendometrioid, and the transitional-like tumors. These are, again, high-grade ovarian cancers that have a distinctive morphology that does not look like a normal serous tumor. But immunophenotypically, they are similar to high-grade serous carcinoma, and they will harbor a TP53 mutation. Now, when we say this, we expect then that they will be positive with PAX8, positive with P16, positive with WT1, and other markers characteristic of serous carcinoma. Occasionally, there have even been mucinous tumors that have been observed to have this type of mutation, and so some people have preferred the STEM acronym rather than the SET acronym. But I won't go there. That's not my domain. So what do we do with a high-grade ovarian carcinoma? Well, I think it is important to establish the diagnosis of serous carcinoma with 2 or 3 positive markers that are supportive of this, in addition to the evidence of a p53 mutation. So I will typically use WT1, P16, very strongly expressed, again positively expressed in ovarian serous carcinomas, as markers along with p53. Now, if I'm concerned about endometrioid, I may also do Vimentin. I may do mismatch repair testing, which would be more commonly abnormal in endometrioid tumors than in serous tumors. And hormone receptors will be expressed differently. If you're concerned about other components, clear cell components, or maybe transitional carcinoma or metastatic carcinoma, these other markers can also enter into the differential and help you to establish or eliminate the diagnosis. Obviously, GATA3, metastatic breast or bladder carcinomas, TTF1 if you're thinking about possibility of lung carcinoma, CDX2 for certain solid types of colon cancer, CK7 and 20, sometimes useful in alerting you that this is not a normal ovarian tumor, P40 or P63 for evidence of squamous differentiation, which may help to underscore the endometrioid phenotype. And then as a last result, if our P53 evaluation is somewhat inconclusive, doing molecular analysis for that mutation. So here's a nice example of one of these types of tumors where this kind of tumor entered into the differential. This was seen at frozen section and was noted to have this distinctive insular pattern of nested tumor cells with central necrosis, as well as broad zones of necrosis, such as we see here. And this fairly solid tumor had a moderate degree of pleomorphism, some high-grade nuclei here. You can see some very nice macronucleoli, abundant eosinophilic cytoplasm, and a degree of variability that on permanent sections raised consideration for transitional carcinoma. There was no background benign Brenner tumor. There was no background ovarian tumor. And the patient, at least at the time of initial evaluation, was thought to have a primary ovarian carcinoma. So we went to work in terms of immunophenotypic analysis, looking at this tumor and looking at the possibilities, all the while clinical evaluation proceeded. So amongst the studies that we did was first off this CK7, which is very diffusely and strongly positive in this tumor, but this tumor was also strongly positive for CK20. So that's not characteristic of transitional cell carcinoma of the ovary. Additionally, this was negative with WT1, negative with PAX8. So then we're beginning to wonder what's going on. Well, about that time, the patient had a biopsy from another site. Distance from this lesion was found to have a similar tumor in that location, which was found to also express these markers. And so further markers were done, and this patient was also subjected to a PET CT scan, which demonstrated fairly widely metastatic disease, including bony metastases, and what looked like it may be a primary lung tumor. Follow-up testing at that point demonstrated that this tumor did show evidence of TTF1, at least weakly in some areas of the tumor. So when it doesn't walk like a duck, it may not be a duck. So keeping metastasis in mind that can mimic a high-grade serous ovarian carcinoma is always important. Metastases to the ovary are not infrequent. Lung, melanoma, breast, and other sites are all possible and not infrequent, and should be considered, especially if your immunophenotypic panel or morphology just don't fit the usual pattern for a high-grade carcinoma. Well, our takeaway clues then from this session: beware of the mimics. Beware of those endometrioid lesions that can persuade you that it may not be serous carcinoma. Assess for P53, assess for that mutational status, and look for any precursor lesion that might be a clue, endometriosis or other lesions that might be a clue that you're not dealing with conventional ovarian serous carcinoma, particularly high-grade carcinomas. Well, thank you so much for joining us for this session. We welcome your comments. Maybe you have other lesions that have temporarily dissuaded you or misled you in the diagnosis of ovarian carcinomas. We'd be interested to know your experiences with that. And as always, please subscribe so that you'll catch our future releases from the channel. And if you like this, we'd certainly be appreciative if you'd share it with your friends who may similarly be able to gain some knowledge from it. So until next time, thanks for joining us.